you also have to understand the treatments, the side effects, the medications, the side effects. I'll give you an example about that. All right. Necrosis, tumor growth, medication side effects can all look the same. So one day Dave's arm is working, the next day it's hanging, he can't move it. Is it the tumor growing? Does he have brain swelling? Okay. Is it some kind of medication, reaction? So you have to know what they all are. Who knows what necrosis is? It's scarring in the brain tissue, okay? That could look like a tumor. Tumor growth, could be making him become more paralyzed. Turns out, given more steroids, okay, it was brain swelling, and the arm moved again. So you need to know enough about the treatments and the side effects to even look at what's going on. I just told you about his impulse control, skin, these kinds of things. And of course, this was all, later on, but that's why understanding what it all means is so important. The other thing that I wanted to mention was you and your loved one make the choice on how, who's going to handle what. First of all, when you take this all over as the caregiver, now you not only have your household responsibilities, okay, but you have their household responsibilities a lot of times, plus you're a chauffeur, plus you have your own work life. If you're a parent, you have your children. Your hats are growing, many, 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 at a time. And you both have to figure out, you're also the decision maker a lot. And I'm not saying that the patient shouldn't be a decision maker too. Dave and I made every decision together. But I was the one that dug out all the information and everything. We made a deal that I was going to concentrate on all that, and he was going to concentrate on being well, on spiritual wellness, on everything he had to do to be strong to fight this, okay? And then I was going to handle that stuff. But I never made a decision for him. We discussed every decision. But I did the legwork. Those are all personal decisions, and that's what I want to say. Everything I'm telling you is from my vantage point, but what I'm saying to you is that you as a family make those decisions for yourself. It might be completely role reversal, and it also depends on, how well the patient is or is not. We were a great team, right up until the end, and I'll get to that about some of the decisions that we've made together. And I hope that you can learn to have confidence in those decisions, and not beat yourself up if you think that maybe you could have made a better one. So now we're going to go on to another hat you're going to wear, and that's building. We're to I said the butcher, the baker, the candlestick maker, but now you're also you're going to build your team, and so now you're a recruiter, a human resource director, and a manager. Because now you have to build your medical team. And I say you build your medical team. And they don't have to all be at one place. It's wonderful to be in a comprehensive center. I mean, that's what we're trying to start here for people who want that, okay? But there's university centers. But let's just talk about doctors, then we'll get to about, locations and hospitals. I believe, and this is my personal opinion, that the neuro-oncologist is the captain of the ship. I did not know that when I first started out, because the first thing was there's a tumor in the head, he had a seizure, he presented with a seizure, we have to get it out. So you go to the surgeon first, a lot that happens. A neuro-oncologist is a combination of a neurologist and a medical oncologist. They know both worlds, and they specialize in the brain and cancer of the brain. A medical oncologist does all cancers usually, okay? A regular neurologist does, all brain stuff. Not to say that neuro-oncologists don't also do other things, but their primary focus is the brain. Okay, brain and cancer, brain cancer. Even if you're not on chemo, and even if you don't need radiation, even if maybe you have a low grade that you're watching, you're not even having surgery or any treatments, a neuro-oncologist can guide you and answer questions to where they need to be. They can order your MRIs, they can order all your work, and you have everything sort of in one hub. And as something comes up that you might need, then they can direct you out. I'm going to tell you some of the team that is necessary to have. And you don't have to write all this down because I'll get it up there eventually. You can write it down what you need, but a neurosurgeon, we know, okay, is a surgeon, a neurosurgeon. But neurosurgeons don't only do brains, they also do spines, a lot of them. What you want to look for is a neurosurgeon that does a lot of brains, okay? You have to determine, what that is for you, what a lot of brains is for you, okay? But that's something for you to understand. A neurosurgeon doesn't mean they're a specialist in the brain, so to speak. There could be a neurosurgeon that is a spine specialist. So that's one thing, to keep in mind. A neuroradiologist. Who knows what a neuroradiologist is? Anyone? Okay. Okay. A neuroradiologist is the person that reads the MRI, but specializes in the brain. We're really lucky here. For a community hospital, we have a neuroradiologist, and his mother actually died of a GBM when he was in college. So he's like very devoted to this, this mission. But the difference between a neuroradiologist and a regular radiologist is that the regular radiologist reads all the MRIs, and the neuro is a specialist in the brain. I am not saying that if you choose the general specialties that's bad and that's wrong and it's going to be wrong. I'm not saying that at all. What I'm saying is this is what's available to you out there, should you want it. The other thing is, and I'm going to mention just something about neuroradiology. When my husband's tumor was progressing, at that time, we were, at the end of the line, and we were on a clinical trial at NIH that you only get on if nothing else has worked. And I was told that there was some tumor progression. But I wasn't 100% sold on this last report. So I called up and I asked the neuroradiologist on duty to pull all his MRIs and to look at all of them together and then tell me what he thought, what percentage or how rapidly he thought things were growing. And that's a different perspective than only looking at the last one or comparing it to one before. It's always good to try to get all your MRIs at one place, if you can, and one that has a neuroradiologist. It's different than if you go to NIH, you're on a clinical trial, you have to go get it there or whatever, but I find that that's always helpful. So then there's a neuropathologist. The top three are, of course, your neuro-oncologist, your neurosurgeon, and your neuroradiologist. They're they get top billing. All these other guys are part of, the ancillary team. But if you don't have a neuropathologist looking at your slides, now your slides are the biopsy that comes back to tell you what tumor type you have. Sometimes that tissue is used to determine what kind of treatment you'll have. When my husband was diagnosed, there was a gene, I think it was 19, I don't remember what they were, chromosomes, that if you had a certain combination, then this chemo would work, but if you didn't, then it wouldn't. And so you needed to have that, looked at. I had my slides sent to Massachusetts General because Massachusetts General, they had a real specialty in neuropathology in that. So that simply means that instead of a general pathology department, that somebody who is brain, really looks at brain tissue for specific things and all the time. Again, it does not mean that the other pathology is wrong. It just is another option for you. And then you have your neuropsychologist. Now, a neuropsychologist can evaluate, they do a series of tests to evaluate any deficits you might have from, your tumor or from the surgery, any cognitive changes. It's really, really a wonderful thing if you can get that test prior to surgery and then get it, after, or, at certain times. There are doctors who will automatically send you for that and advocate for that, and there are other doctors who don't feel that's a priority. I feel that it's huge. And this is why I feel that it's huge. Remember I told you about that impulse control? That's how we found out about it. I wouldn't have known what was going on. I would have just probably kept yelling at my husband, will you sit down? But it was the neuropsychologist that did the evaluation that was able to pinpoint that that was what was going on. Also, if somebody comes to the point where they can't work anymore and disability is an issue, and somebody could live a very productive life and a healthy and a good life, but not be able to do their job anymore, and they look so normal, it's really hard to determine that. If you have had these neuropsychological exams like pre and post, it documents and it shows, what's changed and what the differences, what level a person is operating on and ways that might apply to their job or whatever. So that's the neuropsychologist angle of things. Am I going too fast? Is this okay? Useful? I don't. Okay. All right. So another part of the team would be the radiation oncologist. And again, here's something that's really important. If you are going to go for radiation somewhere, and I can say we're very lucky here. Our head radiation guys came from Sloan, and we have great equipment. I did not come here. They didn't have everything that they have now, and I wasn't here. I mean, I was going to Sloan because of my particular situation for the radiation. I went to Arkansas for surgery. I went to Sloan for radiation. I went to wherever I needed to go for who was the specialist and what our particular, problem was. But there's a difference between whole brain radiation and IMRT, which is very pinpointed radiation. That's something you need to know. When it's whole brain, okay, that's used a lot for brain metastasis. For cancer that spreads to the brain. Whole brain is, I shouldn't even, I'm not a doctor. I'm going to give a little disclaimer here. I'm just going on my experience. But I do know that at the time when your executive functions and your brain is at risk for being overradiated, the pinpointed radiation is what you need to have if you're going to have radiation. A radiation oncologist specializes in the radiation for cancer, and that's very important. So then you have your subspecialties. We've gone over all the major part of the team dealing with the tumor. And your subspecialties are things anywhere from cognitive rehab, because there are a lot of things. Again, I wish I knew this earlier on, and I did not know this at the beginning because I was concentrating on an inoperable brain tumor. But there are certain things that cognitive rehab, there's a difference between regular rehab and cognitive rehab. Regular rehab is if you have a broken leg or something and you're working on it because of a physical break. Cognitive rehab is when your leg isn't working right because of something happening in your brain. And there's a big difference. We have a partnership with Health South. There's a lot of similar things that have to do with as a stroke patient might have or whatever. And so it's important that if you need speech therapy, if you have a little bit of a deficit in your arm or your leg or whatever, sometimes that happens after surgery, or it's swelling, or it's just the tumor. Working with somebody that understands how to work that from the brain angle is imperative, especially speech therapy too, because my husband had later on, again, he didn't have, he could have used a little cognitive therapy for, things we can't see when he was first, after his, when he was first diagnosed because of the seizure medicine and all that. But the second half, when things were more aggressive, he had aphasia. Aphasia means you know what you want to say, but you can't say it. You can't get it out. And originally, I just went to a speech therapist because I didn't know at first. And it was so frustrating because they didn't really get it. Once we were with a cognitive speech therapist that really understood it, it was apples and oranges, and there were ways that, you know, my husband could communicate much better. Then you have like your subspecialties like endocrinology. If you're on a lot of steroids, it causes diabetes. So, you know, I'm giving needles, I'm checking blood sugar, I'm dealing with diabetes now. So that's a whole nother part of your team, you know, if you need it. Everybody doesn't need all of these things. I'm just trying to give you the whole broad spectrum in case you need one of them. The other thing is psychiatrists, if there's somebody, you know, some people that might be depressed from here, which could be, again, tumor placement, or, you know, you need social support. Like I said, we offer you a social worker free, but our supportive programs are things that, you know, are psychosocial support if you need them. And then the other thing, well, I already said the cognitive rehab. So are we kind of sort of clear on building your team now that you see what I meant by when I said you're a recruiter, a human resource director, a manager? You're the CEO of your spouse's brain tumor and of everything in life now. You've become the CEO.